All right. Good afternoon, everyone. Thank you very much for joining us today, both in person and online. We have many participants online as well. So today we have a really nice program that is focused on discussing the use of artificial intelligence to address inequities in diabetes. We have great presenters, people that are actually doing the work, and they'll share their experiences. You will hear about the ECHO program, Bravo model, digital twins, and about personalized diabetes care. Before we start, I just wanted to share a little bit of the background of the meeting. Essentially, what we're trying to do is we are trying to promote collaborations in the Southeast. We have a technology core that is funded through NIDDK, and it's under the Georgia Center for Diabetes Translation Research. And it's a center that is focused on promoting research that translates what we know from basic science, from clinical trials to actually to people, try to help people living with diabetes. And the technology core is focused on expanding those collaborations in the region. We have Ashby Walker. Dr. Walker is our lead here at the University of Florida. We have people from University of Miami, the James Center for Health Research, and University of Tennessee. And we co-lead this with Dr. Nicoleta Serban from Georgia Tech. I'm Francisco Pascal, endocrinologist at Emory. And the goals are to establish a network of researchers working around diabetes and technologies, provide consulting in different technological areas, and also fund projects that are trying to address gaps in diabetes care. So we really would like to invite you guys to join. There's a QR code on the right side. It's very easy. Just follow a few steps, and everyone can join, really, from faculty, postdocs, students, staff, etc. And there's several resources that we have that we'll like you guys to use. We have now more than 50 data sets through the website. You can see there gcvtr.org, and you can request access to those websites. There's a mechanism, and we actually, if you use those databases, we actually can help you publish those papers. So there's 1,500 that can help researchers publish their papers if they are using these databases. On top of that, you get notifications about funding opportunities, not just the ones from the CVTR, but also foundation that we circulate, and about in different lectures. As an example of people that have been funded from our program, we have Dr. Brittany Brueggemann from University of Florida. She's looking at creating a dashboard to improve health equity in type 1 diabetes. And we have Diana Soliman, recently awarded to study utility and acceptance of CGM in Hispanics. So to be eligible for the pilot grant, essentially we want to encourage people to move to the diabetes world. So if you're not doing diabetes research and you're moving to diabetes, you can be actually up to associate professor or professor. We're trying to fund usually younger investigators. But if you're an associate professor and you want to move to diabetes research, there's funding for them as well. This year we have $50,000 for a pilot grant. The letter of intent is due April 1st, and that is just to connect you with potential consultants. If you have some questions about meeting the goals of the center, how do you align with the goals of the center, so we can just help you with that. And the application receipts should be around May. So the collaborations are expanding. So hopefully you can join us. We will promise we will not spam your email. It will be just related to diabetes. Here's again the QR code. It will be easy. So today we're going to start our presentations with Dr. Ashby Walker. Ashby is the director for health equity at the Diabetes Institute here at the University of Florida. And she will give us an initial overview on how to how there's different interventions addressing global inequity in diabetes, and tell us about the ECHO program. Is an amazing program that has been run here at the University of Florida in collaboration with Stanford. So that's a fantastic experience. And then after that, we will have Hui Xiao. He's an associate professor at Emory, recruited actually from University of Florida. And he will be telling us about his Bravo model that he's been developing in the last few years. After Hui, we will have Gian Gabriel Garcia. He's an assistant professor at Georgia Tech. He's working on leveraging responsible artificial intelligence to generate digital role models. He'll tell you about these digital twins and the models that he's developing to address these problems. And finally, we will have Dr. Mark Clements, and he will tell us about the use of AI for personalized diabetes care and tell us about the Rise in Type 1D Alliance experience. So very excited about our program. So we're going to get started with Ashley. Ashley, please join us. And just housekeeping, we will have questions at the end of the sessions, and we will have a panel discussion with all the speakers as well.
Well, welcome everyone. On behalf of the UF Diabetes Institute and the Department of Health Services Research Management and Policy, we thank you for your time and your presence today to talk about such an important topic. In my brief time with you, I'm going to describe disparities that we see that are very pronounced in both type 1 and type 2 diabetes. I'm also going to share with you about the Project ECHO model as a way of addressing health disparities in diabetes. We have this program ongoing here at the University of Florida. And then finally, to really set the tone for today, we're going to consider the importance of addressing health disparities to ensure that AI promotes health equity for all people. I have no conflicts of interest to disclose related to this presentation today. I do have to disclose that I'm currently the elected chair of the ADA's National Health Disparities Committee. Funding for the Project ECHO Diabetes program comes from the Helmsley Charitable Trust and most recently from the Florida Department of Health Office of Rural Health. There was a publication that came out in the Lancet this summer that was looking at the global burden of diabetes. And so what this really important paper did was it looked at where we are right now globally with diabetes rates, but most importantly, predicted where we're headed. So as of 2021, 529 million people in the world live with type 1 and type 2 diabetes. Most of these people have type 2 diabetes, over 90%. But what the article did was showed the staggering direction that we're going in. So by 2050, it's going to be 1.3 billion people in the world that have type 1 and type 2 diabetes. What's really important in this piece is when they were showing the predictions and the risk, where we are going to see the majority of growth in diabetes, especially type 2 diabetes, is going to be in your low-income countries and middle-income countries where there's really not an infrastructure or capacity to deliver diabetes care. So one of the big takeaways from the seminal publication is that when we're talking about the global burden of diabetes, it begs the discussion of health equity. Because when we look at who is most impacted, it is historically marginalized communities that face the greatest risk for type 2 diabetes. And no matter what country you look in the world, and we're going to talk about the United States a little bit, the impact in terms of outcomes, in terms of who is most at risk, tend to be, again, marginalized communities. So this article really focuses on the need to talk about the social determinants of health, to talk about how to address the social determinants of health as we try to meet the challenges of this global crisis. In the United States, even in a developed nation, we see profound differences in outcomes for people living with diabetes. For people living with type 1 diabetes, socioeconomic status matters. So early in childhood, we see differences in people living with type 1 in childhood with highest HbA1c rates and the highest risk for hospitalization for serious diabetes-related complications for our lowest income children. those differences persist across the lifespan. So some studies estimate that for people living with type 1 diabetes from households that are at or below the poverty threshold in the US, they have a 22-year difference in life expectancy than people in the United States who are living with type 1 that are more affluent. We also see differences in type 1 diabetes based on race and ethnicity that persist independent of SES. So even when we control for SES, we see differences in race and ethnicity, with non-Hispanic Black communities facing very high risk for disease morbidity and mortality. And we also see underutilization of really important technologies like continuous glucose monitors and insulin pumps in non-Hispanic Black and Spanish-speaking communities. In type 2 diabetes in the United States, very much in keeping with the Lancet publication I referenced, non-Hispanic Black, American Indian, and Hispanic populations face the highest risk for developing type 2 diabetes. So historically marginalized groups face this elevated risk. And again, we see risk based on socioeconomic status. In type 2 diabetes, people from lower income communities are more likely to develop type 2 diabetes. And then also we see differences in terms of race and ethnicity in type 2 diabetes with disease morbidity and mortality. One of the things that I'm going to touch on today is differences in the utilization that I mentioned before of technologies like continuous glucose monitors and insulin pumps, especially as we're going to have a lot of discussion today centered on how we leverage data and information that we have on people to implement AI programs. In the management of type 1 diabetes, continuous glucose monitors have a lot of benefit, and there's growing evidence to show that using a CGM or a continuous glucose monitor can improve somebody's HbA1c. It can reduce risks for hospitalizations, and it's seen as the standard of care when you look at the ADA's guidelines for technology use in type 1 diabetes, and now for anyone who requires insulin in type 2 diabetes. So then we have to ask the question, why are these technologies that could have benefit to people who most need them being underutilized? And the answer to that, as many of the students in here in public health know, is that it is a complicated array of things that can yield those disparities. So in public health, we use something called the social ecological model. We use this widely to better understand health outcomes. So when we're talking about disparities in technology use, we can't understand an individual's decision to use or not use a technology unless we understand the world in which they live. They live within a specific family, they live within a specific community, and they live within a specific historical context. And what is really important, and it's going to come up later today in another talk, is policy. So if these devices are not covered for people, that is a tremendous barrier for utilization. But what we found in our own research that we've published here, I'm showing an article that was in Diabetes Care, is that there's also barriers at the clinic level with providers. In fact, Dr. Brueggemann in her seed money grant is addressing the provider level barriers for implementing technology use. So the takeaway is that in order to really address these complex challenges, we have to understand that the individual is within a specific social context, and we have to have multi-layered interventions. What we've also learned and what we know is that people living with type 1 and type 2 diabetes are guided to see endocrinologists 4 times a year for preventative care, but that doesn't always happen. And so while we would like everyone living with diabetes to see endocrinologists, there are, again, different barriers that keep people from utilizing endocrinology care in the United States. So we have a lot of different articles that we could point to on this. People in rural areas might have a hard time accessing an endocrinologist. For people who are from working poor communities, even if that visit is covered, to lose wages from your job to go to a preventative care visit is a cost that some people cannot absorb. We also know that for people in very close proximity to multiple in-network providers, sometimes people still don't go see an endocrinologist. And some of our research shows that there's a lot of reasons for that, but it might be because of feelings of shame and stigma that they feel in those clinical encounters. So for all of these reasons, what we see in especially type 2 diabetes care is that over 90% of type 2 diabetes care is being done in the primary care setting, not in endocrinology settings. And for people who live with type 1 diabetes who are adults who are low income, 65% of them solely rely on a primary care provider for all of their diabetes care needs. This is where the Project ECHO model comes in. And so ECHO, when we say that word, stands for Extension for Community Healthcare Outcomes. This model was established at the University of New Mexico in the early 2000s, and it was a way to try to reach people in medically underserved areas who don't see subspecialists for care. And this model is really founded on the belief and the understanding that oftentimes underserved communities are going to rely on a primary care provider. And so you have to empower the primary care provider in a family practice setting to be able to do subspecialty care. This cannot replace a subspecialist, but rather it empowers primary care providers to be able to meet the challenges that they face when they go to work every single day. So this model started at the University of New Mexico. You might hear someone say Project ECHO is telemedicine, and just to clarify, it is not traditional telemedicine where an endocrinologist would be giving remote care to somebody somewhere. This is a provider-to-provider empowerment model where a group of subspecialists that are referred to as a hub team in this model train what are called your spokes. And your spokes are your primary care providers or your health centers. So the way ECHO works is through teleeducation. Zoom is used as the platform, and a multidisciplinary team, and I'm using an example of diabetes here, but I want to be clear, Project ECHO is used in so many different areas of chronic and infectious disease management. You have a hub team that has, in our case for diabetes, pediatric and adult endocrinologists, clinical health psychologists, pharmacy specialists, social workers, and we provide training to who are called our spokes, who are the primary care providers, so that they better understand how to do diabetes care. The first 30 minutes of an ECHO session is a learning topic, and people receive continuing education credits for watching. And the second 30 minutes is a de-identified case presentation that is all teach, all learn. Again, just to show you the scale of this, ECHO is being scaled rapidly. It's being used not only all over the United States, but globally to meet the challenges, again, of so many complex chronic diseases, infectious diseases, and we're also seeing a lot of new iterations of ECHOs that reach beyond those two scopes. So here at the University of Florida, we got funding to do a Project ECHO diabetes program from the Helmsley Charitable Trust. We do this program here at UF in collaboration with Stanford in California. So I work here at the University of Florida with Dr. Michael Haller, and we are the leads here. And we work alongside our colleagues at Stanford, Dr. David Ma, Dr. Rayhan Law, and also Dr. Adala. Our team at the University of Florida, that is our hub team, constitutes what I talked about before, which is a multidisciplinary team of people that can provide training to primary care providers about doing diabetes care. We have a really rich, wonderful group of people that represent different disciplines and different aspects of diabetes care that are critical to empowering our providers. So in our implementation of ECHO Diabetes, we offer provider education that I mentioned before. That's our 1-hour tele-ECHO sessions. We provide real-time support with our spokes with complex medical decision-making. We also offer diabetes peer support coaches, which really involved a hybrid of a community health worker model and a peer support model. And then they have access to an amazing online repository of information. One of the unique things about our ECHO program is that we really targeted federally qualified health centers as our spoke sites. So not just any primary care providers, but PCPs and FQHC settings. Federally qualified health centers provide care to over 30 million people in the United States. Many of them do not have health insurance, or they might be on Medicaid, but then move into the uninsured category depending on the circumstances of their life. The other wonderful thing about FQHCs is part of the federal funding guidelines, the providers have to match the demographics of the communities they serve. So not only is this allowing us to reach really diverse communities that are at risk for so many health disparities, we're able to reach their very well-trusted providers who are also diverse. We have been implementing a stepped wedge design to measure patient level, provider level, and center level outcomes. And in our analysis, it involves a cohort of over 32,000 adults with type 1 and type 2 diabetes in the FQHC setting. Just to give you one of our big takeaways that we're now in the process of publishing, we have about 15 publications on the Project ECHO program, but our main findings we are just now pushing out. But we saw statistically significant improvement from pre and post intervention in the use of CGMs in our FQHC populations, which is something to really celebrate when you're talking about trying to reduce these disparities we see in tech use. We also saw a statistically significant improvement in HbA1c across the health centers that are participating in our program. The Lancet piece that I opened with today that was focused on the global burden of diabetes that was released this summer came out concurrent to a series of articles that was commissioned by the Lancet to address this issue of inequity in diabetes globally and what we're going to do about it. I had the honor of serving as the lead on an international working group where we were charged with writing a paper to showcase interventions that are ongoing in the world today where people are trying to tackle these complex challenges. And the message is we have to believe that there is hope and that there are things that we can do to make a difference, to be agents of change. In this article, we presented a theoretical framework. You should see the fingerprint of that social ecological model at the center of this. We really challenge people through this by looking at programs that are happening in Africa, in India, in Australia, and the United States to consider that individuals do not exist outside of social context, that individuals exist within a larger social structure that really makes it hard to thrive with this disease because of things like structural inequity. We challenge people to improve the clinical practice environment, to change the ecosystem, and to build capacity so that we have a world where there is more equity for people living with diabetes. In conclusion, interventions to address disparities in diabetes must be multi-layered and they must be multi-sector. Primary care providers play a really important role in the delivery of diabetes care in the United States, and FQHCs are a really important partner for us when we're trying to address health disparities. When we think about our FQHC population and the direction we're headed, especially in type 1, with technology, with time and range, with all of these things, our communities are in a very different place in the FQHC setting where technologies really are new, they're not being widely utilized. And so we need to make sure when we have these discussions about AI and new AI initiatives, especially that involve CGM and pump data, that we are remembering that we first must address disparities so that people have access to that technology. Thank you.
Okay, guys, can you hear me? All right. Okay. I really need your attention, please, because initially I thought this whole hour talk was just for me. So I create like 50 slides, and only through last night's dinner, I learned that there are other speakers. I'm only allowed to speak like 15 minutes. So I really need you to hang on with me and bear with me, like focus, really focus, like you were attending a Taylor Swift concert. Okay. All right, so you already read the title, so let's skip this. And the first slide, I don't like it, so let's skip this as well. Okay, all right, so we're not that fast. Okay, so the last few decades is a miracle for us, right? We have witnessed so much development in the diabetes treatment side. We have two classes of new drugs with many products, SGLT2 inhibitors and GLP-1 receptor agonists. So each of the class possess tremendous value in terms of its cardiovascular benefit, the renal benefit, the weight reduction benefit. So we are now really in a stage that there are very good treatment to treat diabetes. And what's even makes it better is that every day there were new trials finished and there's new real world data showing that these benefit actually real in the real world. And there is not much of a concern in terms of adverse effect. And even with those growing evidence, one of the leading organizations in the United States, American Diabetes Association, start to revise their clinical guidelines, start recommending the use of those two treatments. So everything went really good. And according to one of our research, there's people, so this graph shows the market share of the product. And the two areas on the bottom are SGLT2 inhibitor and GLP-1 receptor agonists. So these graphs show that over time, people start to pick up those newer treatments on the market, which is really, really promising. But is that good enough? So one important lesson we learned from the original Batman trilogy is that if you're good at something, never sell it for free, right? Same goes to the pharmaceutical market. Think about this surge in the use in the clinical practice. So it absolutely have an impact on the market. Both of the drug, SGLT2 inhibitor and GLP-1 receptor agonist, their price almost doubled or tripled since its market interest because of the growing evidence about how good this treatment is. And according to a report 2 years ago, among all the people who should receive those newer treatments to achieve the optimal health benefit, only like 9% receive SGLT2 inhibitor and 7.9% receive GLP-1 receptor agonist. So that's the reality on the current clinical practice. And according to one of our study, we provided a dissemination analysis, basically trying to explore what's proportion of the variation in this newer treatment uptake explained by the variation of different factors in the population. What we found is that the patient's economic status explained 50% of the variation in terms of the drug use, but its actual clinical indication only explains 20% of the drug use. So in other words, whether a person use the newer treatment or not is not determined by if he needs it, but more of if he can afford it, if he can afford it. And in another study we published on the Annals, we found that only 1 out of the 10% of the US patients with type 2 diabetes who made the recommended criteria to use their newer treatment are actually using the treatment. And the even more interesting finding is that among people who made the indication and should be prescribed those two classes of newer treatment, there's only 9.2 of them were actually using it. But among people who not recommended to use it, 11% actually afford it. So this is the funny part and the things we were dealing with it nowadays. Like people don't use it, they can actually the people who can afford it. Wondering how that happened. And what makes things even trickier and even more tricky is that because some of the glucose, some of the newer treatment, like the semaglutide, tirzepatide, which were all over the news nowadays, right? They're like the perfect drug for the weight loss. And it's even approved by the FDA beyond the scope of diabetes, but to control the weight loss and weight reductions. And can you think about how many people can meet this indication of weight control in this country? It's just too many. That's why, like the Medicare, they declined reimbursement for this kind of newer treatment among the weight loss for the weight loss purposes. So now we're really in the best time of history that we have so many treatment for diabetes, but also the worst time of the history that you have so many good treatment, but you just cannot afford it. So what could be a possible solution here? So one thing we learned from all the trials is that there's a huge heterogeneous treatment effect of a single drug. So among a group of people who were put on the same drug, people benefit really well, and some people benefit not that much. So there's a huge heterogeneous in terms of treatment effect. And these heterogeneous treatment effect lead to also the heterogeneous of the economic value of receiving this treatment as well. We talk about economic value because this is what the payers cares about, and the language the payers talk about, right? So there's a huge alignment about who received the highest clinical benefit and who received the highest economic benefit between these two aspects. And historically, there were numerous prior research supports to use the policy level intervention to improve the treatment access among the very expensive drug to first remove the barriers in the targeted clinically high benefit users. And how it's relevant to the fairness and equity is that the people with the most severe socially disadvantageous status, they have the highest gap in care, and they have the highest risk, and thus they are potentially be the people with the highest clinical benefit. So in other words, a policy that identifies the high benefit users and remove the barriers for them to access the treatment initially can actually have a very nice spillover effect that benefit more people from the socially disadvantaged subgroups because they have a larger gaps in care. And our job is to identify this group of people and provide strong evidence about what is the benefit of target this group, what are the solutions that remove barriers first from these high benefit users so that we can also have a nice spillover effect to reduce the health disparity. This is its angle about precision medicine and precision public health. And because different people respond differently, different people benefit differently, and have different economic outcome as well. So with the same treatment, there will always be more suitable patients for a specific treatment given the limited resources. Okay, so today we're not going to be just talking about one study, we'll talk about the areas. So for this thing, this whole precision policy area, there's 4 avenues of research. Each of them can lead to a strong avenue of funding. So two areas are the methods area, and 2 areas are the implementation areas. So the 2 methods area are the disease progression model and the heterogeneous treatment response mapping. So let's talk about the AI-based algorithm to study heterogeneous treatment effect. So remember, even for the same treatment, different group of people benefit differently. There's already a lot of machine learning algorithm on the market that we can use and apply them to the large randomized clinical trial or real-world data to really understand and pinpoint the subgroup people who benefit substantially higher as compared to other people for a single patient, for a single treatment. And if you apply this algorithm on a sequential data, this algorithm can even help you to understand the potential mechanism, how these treatments are effective in a certain population. And through that, you can generate a comprehensive profile about how patient-level factors modulate the treatment effect. This is one of the outcomes you can achieve by applying this kind of algorithm. Basically, this is going to be a polymetric benefit score where you have a bunch of clinical relevant indicators and assign different weights to that indicators. So eventually, for each patient you taking care of, you can calculate a suitable score for this patient that indicates whether the use of this medication can achieve substantial outcome or it's just as comparable as some cheap alternatives. We currently, funded by the NIH, we currently do this full neural treatment mapping across all the diabetes treatment. We use one Florida database to train the model, develop the algorithm, and we use another PCORnet site, the RichNet, to validate our algorithm. So that's just one area of the research. Another area of the research is the micro-simulation model, which is also very relevant. So what is a micro-simulation model? So the micro-simulation model is a model that developed based on the machine learning. So you first have to have a very large longitudinal data. And then when you apply that machine learning algorithm, you will be able to develop a model that simulates how the disease progresses. So what does the model basically do is that eventually, after you develop the model, every person go to your clinic, you can run this model and predict this person's outcome, health outcome, cardiovascular outcome, renal outcome, healthcare utility, and everything. So this type of model is capable of prediction a wide range of outcome. For the model my team developed, this is called the Bravo model. It tracks the progression of all the organs within an ecosystem within a person's body. So it tracks the brain health, cardiovascular health, microvascular health, and have these large number of outcomes to be predicted given the patient's clinical traits when they visit the clinics. So how these 2 areas link together? So the disease simulation model predicts the health outcomes. And the heterogeneous treatment effect profiling is a module that plugs in the simulation pathway. So in that logic, every time a patient comes into the clinic, you have a simulation model, simulate the outcome. And you can simulate all the different therapeutic strategies based on the study heterogeneous treatment response module. You simulate all the options so that you can actually come up with the best therapeutic strategies, and also based on these, the policy interventions that remove the economic barriers. So now we can talk a little bit about the application works. Don't like this, don't like this, okay. All right, so one of the project we did is that we developed a large AI model called the Bravo Go, which housed the Bravo simulation model, the comprehensive treatment effect profiling, and the RCT data. What this AI do is that it automatically extracts information from a person's EHR and run the simulation through all the possible therapeutic recommendations, and push back the information about which strategy is the best one, actually the top 5 strategies, and the associated benefit and outcome with the strategies, and push it back to the Epic so the clinician is able to see the outcome and make clinical judgment. It's currently funded by the NIH, and the clinical sites is run by at the Chulan Hospital. So yeah, so eventually this is basically what this AI do in the clinics. And in terms of public policy, so the one of the iconic thing we did is we helped the White House to figure out the insulin copay policy, because a couple of years ago, insulin was extremely expensive. The Medicare was seeking solutions to reduce their insulin copay, and they came up with policy that how about the Medicare pay for most of the money, and every patient only need to pay for $35. And at that time, I wrote a paper basically saying this is maybe a policy out of good heart, but it have a very severe and bad economic consequence. And then I was actually reached out by the Joe Biden's administration, actually the budget planning committee run by Bernie Sanders, about the next phase of this policy, which is expanding this policy to the private insurance as well. So I basically provide a lot of evidence to them. Half of the evidence supported the benefit of the policy, but most of the evidence supported the downside of the policy. And they just incorporate all the good evidence about the benefit of the policy and decided to roll this policy over to a broader consequence. So I was really angry. So I brought this paper and also published on Diabetes Care saying this is ridiculous. So basically, if this policy should work, you have to reduce the drug price by 70%. Otherwise, over time, it will basically destroy the ecosystem of the Medicare. And what is interesting is that after the paper was published, like 2 months later, a lot of the pharmaceutical companies start to have this news release that they decide to reduce their price of insulin by 70%. There's also caveats in this, but this is the effort that they do, that how this research fit in the scope of precision medicine. And we also have other approach that we investigate how the economic return of this medication varied by different patient characteristics. We found that in terms of SGLT2 inhibitors, the patient's CVD risk and patient renal function modulates the economic return substantially for this drug. And we also come up with a poly risk integer score to help the payers to determine among what groups the cost barrier should be first removed in order to facilitate the maximized health output. Yeah. So in a nutshell, there's so many new areas in this precision medicine, precision public health domain based on the AI, but it also has many challenges as the traditional analytical approach. So we need to be very scientifically conservative, but also rigorous and be adventurous. So yeah. Okay, that's it. Thank you. We're right on time.
Appreciate it. All right, we're gonna skip Wei's Q&A. I'm really excited to share my work here with everyone on leveraging responsible AI to generate what we're calling digital role models for patients with type 2 diabetes. Before I get started, I want to just make sure I acknowledge the funding source for this research. This research is funded by the NIH AIMA Head Consortium, which is specifically focused on research related to equitable AI for different areas of healthcare. I also want to give credit to the research team that's really made this work possible. So this is a multi-institution effort comprised of PhD students, undergrads, and and faculty across 3 different institutions, Georgia Tech, Emory, and Texas A&M. So today, the focus of all these talks have been AI. And I think we all have the same question in mind. I went ahead and asked an AI that I think many of us are familiar with, ChatGPT. And I said, ChatGPT, will AI replace doctors? And as ChatGPT does, it's on a very lengthy response, trying to cover all the details. But to summarize, they said, well, the good news is AI is not going to replace doctors entirely, but there's the hope that it will transform medicine. And in fact, it's likely that AI, rather than replacing doctors, will augment their capabilities. Now, ChatGPT, I'm like, is ChatGPT right? Are they wrong? It turns out that the president of the American Medical Association was asked the same question. And Jesse responded that it's clear to me that AI will never replace physicians, but physicians who use AI will replace those who don't. So I think a lot of very smart people and smart AIs are kind of looking ahead and seeing, there's this kind of interface between medicine and technology that we really have to leverage as we move into the next generation of medicine. That being said, there's no free lunch. There's a lot of evidence that AI has the potential not just to advance care, but also widen existing health disparities. And this particular example that I picked looked at kind of how different AI technologies, in this case, like AI for looking at image analysis, were kind of widening and perpetuating racial inequities that were already existing. So if you've been following kind of recent pushes by the White House, you'll see that they recently have this major interest in what they're calling responsible AI, and how as we're getting into the next generation of technology, we want to make sure that the technology that's being developed is quote unquote responsible. So with all of these kind of different challenges in mind and the way technology is trending, we were really interested in designing a responsible AI for diabetes care. But what does that mean, and what does that look like? So the work I'm sharing with you today, it's some preliminary work with some pilot data, and I want to share a kind of big picture where we're headed. And in particular, when I talk about responsible AI for our setting, we kind of care about 3 things. One is robustness. How well does our technology account for uncertainty in the data that it's being fed, and uncertainty in the way that people's health evolves over time? Interpretability. So do the people who are being affected by this technology understand what's happening? And do they understand why they're receiving the recommendations that they're getting? And finally, fairness. So I showed that slide a couple seconds ago about perpetuating health inequities, but there's many dimensions of inequity in healthcare, and we want to be mindful of that as we're designing kind of the future technology that we're using in diabetes care, so that we can hopefully mitigate the likelihood of providing unfair recommendations. So if we're able to achieve all 3, we're happy. This is our version of responsible AI for diabetes care. So what exactly are we doing? So when we started this project, we were really interested in this idea that we have in the US a growing population of people with not just comorbidities, but multiple comorbidities. And type 2 diabetes is one of these, and people with type 2 diabetes tend to have hypertension, for example, among other chronic diseases. And the more chronic diseases someone has, the more comorbidities someone has, the more challenging it becomes to do treatment planning, right? Because you have to not just account for one disease, but multiple diseases in conjunction, and you have to kind of weigh the costs and benefits of different treatment options. So we found that there's this emerging type of AI called counterfactual explanations that we thought could help facilitate treatment planning for these types of patients who have kind of complex presentations and multiple comorbidities. And the way this algorithm works is by recommending what we call digital role models. So imagine you're a clinician and you have a high-risk patient walk in. They're high risk for some adverse outcomes. Say, for example, the risk of cardiovascular disease is high. And you go and you run your counterfactual explanations algorithm. And what it does is it goes into your patient database it tries to find a patient who looks very, very similar to your patient, but the difference is that this person is low risk. And now we can use this low risk person as a role model for whom we can extract treatment recommendations or treatment targets that can help to augment and support the treatment planning for our high risk patient. And again, this algorithm kind of already exists in a more theoretical sense. And we wanted to make sure in our work, we're tailoring it not just to diabetes care, but also to the tenets of responsible AI that I outlined earlier. So how do we do this? So, well, first was this kind of notion of robustness. And one thing to keep in mind is whenever we say, oh, a patient is high risk, usually we talk about some risk estimation tool that's embedded in EHR that might tell us that, or a risk calculator that exists online that's built out of many, many studies. And these risk models get updated over time. And in fact, this is a well-known phenomenon in machine learning called data set shift, where the underlying data that we apply these models to might shift over time. And so we have to update our models as well. So with that in mind, we kind of want to avoid the following situation. So suppose today your patient comes in, algorithm says, hey, they're high risk. We find them a nice role model. And our patient goes and does everything perfectly, right? They follow all the treatment recommendations with 100% adherence. This is our like gold star, ideal patient. But then sometime between now and their next visit, the risk model updates. And because of that update at the next checkup, it says, hey, I know you did everything right, but you're still high risk. And this can happen, right? This can happen if algorithms are being updated under the hood. Like we all get updates on our apps and different programs and stuff automatically. And so it's not unreasonable to think this also happens with the risk tools that we use in practice. So we were able to try to avoid this problem inherently in the design of our model. In particular, we use this framework called data-driven robust optimization, and I will spare you the math, but in general, what we wanted to do was build an algorithm that tried to minimize the amount of effort that our high-risk patient needed to kind of meet the treatment targets of the role model. But at the same time, we want to constrain the solution space of this algorithm so that there's high probability that the role model we choose is still going to be low risk in the future based on historical data we have about how these risk estimation models evolve over time. So that's how we took care of the robustness side of this. In terms of interpretability, we also kind of figured, by the design of digital role models, this is actually, I think, a relatively interpretable framework to begin with. Because, we have our patient, we know a lot of things about them, we have a lot of information in our EHR, and whenever we pick out the role model, we can look at all the same measurements, right? And we can look at all this person's treatments, and this can help us decide, what treatment target should we set, what treatment plan should we set. So clinicians can then leverage their own knowledge of known risk factors and treatment effects and compare with the patient and role model and use that information to set treatment targets. So here again, we're trying to augment clinical decision making. So we did some proof of concept experimental setup using data from the Accord trial. This was a cohort of 10,000 patients, most of whom were high risk for cardiovascular disease. And we used risk estimates from a validated ASCVD risk calculator. And we were considering 5-year risk, and anyone with a 5-year risk of ASCVD more than 0.2 or 20% was considered high risk in this experimental setup. And just to give a snapshot of kind of some of the results we got, if we plotted the different risk scores over time based on how these risk estimation models might change, you'll see that our high-risk patient had really high risk scores. Like this person had extraordinarily high likelihood of an ACVD event within 5 years, but it's also highly variable, right? Like if these risk models change over time and they're updated in real time, then the risk scores can also be all over the place. But the role model that we chose, thanks to our algorithm, because it was designed to be robust, were all under this high risk threshold of 0.2. So this is, kind of the importance of making sure we account for this type of uncertainty when we build our AI. So we have a lot of other results, but I kind of want to jump ahead to, I think, what is really interesting now in terms of our next steps, which is what about fairness, right? Like I showed robustness, I showed interpretability, but what about the fairness piece of this? So again, when we were first testing this out, we had originally done our pilot data on Accord data, which is a nice clinical trial, but that cohort wasn't necessarily diverse or representative of what we'd see in the US. So we took data from NHANES, which is a more like nationally representative survey. And we tried to see, well, how well does our algorithm work with some small cohort of NHANES data? And we found that whenever we stratified outcomes by sex and by race, it turns out that, in terms of sex, we don't really, or gender, we don't really see very much difference in terms of mean risk reduction or projected risk reduction. But we do see some weird trends in terms of race and ethnicity. So you can see kind of on all the graph on the right, the upper tails for non-Hispanic whites tends to be a lot higher. So they tend to have higher risk reduction than their Hispanic or non-Hispanic Black counterparts. And we were kind of intrigued about why this was happening. Was it our algorithm? Was it our data? And it turns out that it had to do a lot with the data, right? So when we talk about AI and these algorithms, it's not just how we design it, but also what we feed into it, garbage in, garbage out. And so in our case, we found that like when we talked about female patients, Hispanic patients, non-Hispanic Black patients, there were just fewer potential role models for them in our data set. And this is because we constrained it so that like, your role model had to be the same gender and race as you because those are things you can't change. So this kind of leads us to the next steps, which is what we're working on now, which is how do we enhance the future look of this algorithm? So we've kind of pinpointed several avenues to research. So one is the idea of designing responsible risk estimation models. Can we take the bias out of the risk estimation models themselves before we even do any recommendations for digital role models? And as I alluded to in the previous slide, can we also design our algorithms so that it's using representative databases so that most people have a fair shot at getting a good role model? And then finally, we want to make sure that whenever we talk about health equity, we achieve this in the underlying design of our AI. So currently, we're not just thinking about this from a mathematical perspective, but also we're interviewing clinicians, we're interviewing patients who might be affected by this technology, and trying to understand, how do you, what do you think about the implementation of this technology? What barriers do you perceive? And what scares you in terms of the health equity side? So with that, I'm gonna finish it up here and pass it off. Thank you.
Okay, can you hear me okay? Yeah, perfect. There we go. Okay, thank you everybody for being here today. Thanks to Ashby Walker and the other organizers for inviting me to be here. It's been lovely to see Gainesville and to see the campus for the first time. I'm going to talk a little bit about the Rising Tide Alliance initiative at Children's Mercy Hospital in Kansas City. These are my disclosures. I do have one commercial engagement that is independent of my academic work, and you can see some of my research support. So, the first question I usually begin with is how do we think we're doing in type 1 diabetes care? And the answer is that despite the incredible advances in insulin technology and the incredible advances in hardware technology like continuous glucose monitors, insulin pumps, and automated insulin delivery systems, we still only have a fraction of our young people meeting their glycemic targets. And they are still plagued by diabetes distress every day and lower reported quality of life. So I think we have a long way to go, and that these technologies, while they have helped us make incredible strides, are not the last and final answer. We need something more. So what is the Rising Tide Alliance? It conceptually is an initiative to rapidly increase the deployment of care delivery and behavioral interventions in diabetes care, many of which go through the research development pipeline and then die on the vine because they never get implemented or disseminated at any other center. And in fact, often don't get implemented or disseminated clinically at the center where they originated. They remain in the research realm. And you can see we've had support from the Helmsley Charitable Trust, which has been a theme a couple of times today, and that we've got assistance from other collaborators at other institutions. The vision of this is to improve outcomes, patient experience, the value of care broadly across stakeholder groups by getting in front of clinically important problems, by predicting them, by introducing innovations at a very early stage in care, by studying their implementation and rapidly iterating on them, and then eventually disseminating to other centers, which is the stage that we are at now. What do we hope to accomplish? Really what my career goal has been, which is to vertically transform diabetes care by creating an intelligent system that is more innovative, more participatory, and is more empathetic. And a corollary to that is we have to be able to move at the speed of light. Like there are so many barriers to innovating in clinical care at an institutional and policy level, and we have to be able to move much faster. So our story begins in an interesting place in the land of Oz, where I live in Kansas, where we have a lot of tornadoes, and weather predictions become very important to us so that we can prepare, shelter in place, plan ahead, et cetera. And I've thought for some time, why is it that I can get a decent weather forecast, but I can't get a forecast on whether my patient's going to be admitted to the hospital, or a forecast on what their blood glucose, their glycemia will look like in 3 months? Why is it that we have much better technology for the weather than we do for medicine? So we conceptualized that we could begin to understand our patient population better if we could take all of the available data, recognize that our population is diverse, that it has diverse risk for any particular outcome, and presumably diverse responsiveness to any intervention we put in front of them. Whether that intervention in the lower right are the primary therapies of drugs, biologics, devices, or surgeries, I don't want to leave the surgeons out, or are what I consider the wraparound services like behavioral interventions or care delivery interventions. And if we could stratify patients using these biomarkers, we could then try some stuff that might be relatively low risk to implement in clinic that would alter human behavior in the home setting, and perhaps alter human behavior in the clinic setting, meaning us and our colleagues, in a way that drives maximal health, if you will, for the maximal number of individuals. And so you can see we have remote patient monitoring, digital therapeutics, peer mentoring listed here, and I'll show you a little more of the flavor of that. So we started by working with a data science company, and then eventually imported all of that skill into our own research team. So we now have a team of 8 data scientists working on this project. And we began by building 3 different forecasting models that operate over 3 different time periods. One is a model that predicts 90-day change in hemoglobin A1C. Some of us know that A1C changes dynamically across childhood. About 20% of patients will have a dramatically rising A1C from age 8 to 18, while others will have a stable A1C. So we thought if we could forecast change from one clinic visit to the next, that we might be able to do something useful to prevent that long-term trend. We also developed a model to predict 6-month risk for hospitalization due to diabetic ketoacidosis. And we have a model that we developed to predict 30-day change in time in range. Now we're shortening that time window to 14 days to predict 14-day change in time in range. How did we start? We started by taking the everything in the kitchen sink approach. Basically, we feature engineered everything that we could get our hands on from the electronic health record, including all of the discrete data in the form of vital signs and laboratory measures, natural language processing derived features from our free text clinic notes, many different note types, phone notes, clinical encounters, notes that were generated in other clinics, like an orthopedic surgery visit for a broken leg, et cetera. And then we imported all of the available device data from continuous glucose monitors, glucose meters, insulin pumps, smart Bluetooth insulin pens. And I'll explain a little bit later how we did that. But we fed all of this into these models. Our A1C change model included over 1,700 features initially. Our model for forecasting DKA in the next 6 months included over 600 features. And the reason we did this is that we wanted to find out, at the risk of overfitting, how high the performance could be for these models. What's the best we could do? And once we did that, we then took a few steps back and we said, can we now create a more parsimonious model? A model that includes only a few features and features that might help us to create a more explainable prediction. And can we then translate that into an output that is understandable by clinicians? If I tell a clinician in the electronic health record, your patient whose A1C today is 8.5 is going to have an A1C of 9.1 in 3 months, I'll look at that and they'll say, great, what do I do? So we had to feed it to our clinical team in a different way. And the way we decided to feed this information to them is to create rank-ordered lists. Lists that raise risk, the highest risk individuals, to the top, so that we can essentially have a work order list where our team can start to say, okay, we may have capacity to take 10 individuals off of this list this week and send them down a different pathway of care. And that's all the capacity we have. But it's something that they can digest, something that they can take action on. We also decided to transform our care model from the in-clinic care model where 4 clinic visits a year are delivered to essentially everyone if they make it and attend those 4 clinic visits a year, to a model that really leans into remote patient monitoring. So recognizing that we can deliver care via home telehealth visits that are small, bite-sized, 10-minute encounters. And why? Because if you want to impact human behavior, if you want to impact outcomes, we really can't do it with 4 encounters a year. Even the data from the DCCT suggests that individuals who have more frequent contact with their care team do better. When you take that frequent contact away, even in the context of intensive insulin management, they do a little worse. So if we recognize that our patients spend 0.03% of their waking hours in clinic with us, it becomes clear that we have very little opportunity in the current model to move the needle. And if we can create a virtuous cycle where data is being shared with the diabetes center has the opportunity to take action between brick and mortar clinic encounters, then we might be able to have more frequent touch points to move the needle. I will also point out that an advantage of this approach is that CMS in 2019 approved billable codes in our fee-for-service model in the US for remote patient monitoring. And remote patient monitoring plays well when you're talking with value-based care organizations who are trying to move the needle on quality outcomes. So in both environments, I think it plays well. What is it? In our case, a physician or diabetes educator uses either a video platform or just the plain old telephone. So this works for people with flip phones too. Essentially engages in blood glucose management review, problem solving, dealing with urgent issues, and goal setting. And the more frequent contact allows them to check in more frequently on whether goals are being achieved. So there are billion-dollar companies now that are offering to perform remote patient monitoring for the patients in your clinics. And those companies are generally offering one flavor of RPM for each disease state. We are thinking about how to create 31 flavors of remote patient monitoring. So I'll talk about that in a moment. What have we found so far? Well, by taking patients off of a rank-ordered list, in this case, people who are predicted to have a rise in A1C that's clinically significant in the next 90 days. If we just simply look at pre-post outcomes, which isn't very rigorous, And we asked how many people were predicted to have a rise in A1C, knowing what the performance of our model is, and how many people actually had a rise in A1C in the next 90 days. We see that the pre-post outcomes suggest that we've reduced the number who have a rise in A1C compared to what was predicted. We went a step further than that because we didn't want to undergo the time and expense of a randomized clinical trial. We wanted to implement this in clinic, and we wanted to have some way to rigorously evaluate the outcomes. So we developed a tool for dynamically propensity score matching an intervention population in our clinic with a cohort that looks very similar to the intervened cohort but has not received the intervention. And when we compare those two groups, we find again that we have achieved a clinically significant reduction in the proportion who have a rise in A1C. So that to us is a win and a starting base case for how we can create additional flavors of remote patient monitoring intervention that are evidence-based. The way we started by creating behavioral interventional pathways is we started with the pillars of diabetes self-management, and our team began to map those onto intervention strategies that are supported by psychological theory, that may have some evidence base in pediatric type 1 diabetes or may have some evidence base in other pediatric or adult disease states. Some of these include, behavioral economic interventions. So we actually have a pathway where we're paying teenagers to take insulin at mealtimes. Some of them involve cognitive behavioral therapy strategies delivered through a digital format to treat diabetes distress, not only in the child, but also the parent. Some of them involve partnerships with commercial entities. So there's a commercial entity that has a relational agent in the form of a mobile app. Relational agents in psychology appear to elicit more engagement from humans than chatbots or text messages. And so we're currently testing that strategy and so forth. We've also created a process for taking any one of these interventions through what we call an intervention sprint, which is to deploy them in clinic and then to undergo multiple plan, do, test, act cycles using the Deming wheel to evaluate whether there is any initial evidence, again, using propensity score matching, that they're moving the needle on the outcome that we're trying to improve. And if they do, then we double down, we adapt, and we try to make it more robust. And sometimes we pull these out and we say, okay, now it's time to write an NIH proposal and go conduct a randomized trial. Okay, so we're not replacing randomized trials, we're collecting evidence prior to performing a randomized trial. I'll give you one example of what we're doing that doesn't involve any AI. It is an intervention, a screen to refer intervention in our clinic that connects families automatically to resources in the community if they endorse a social barrier to health. And the social barrier to health is most commonly food related. Sometimes it's transportation or meeting rent or utilities. And so we are now able to screen for these in clinic robustly across the entire population, and then we're able to automatically make a referral to community organizations and receive follow-up on whether they receive the service. We use the findhelp.org platform. It's rebranded for us as the Lift Up KC platform. This is what the patients and families see. And this has a typo in it. It says referrals made through Lift Up KC. This is screenings that lead to referrals through Lift Up KC. And since 2021, these data are a little old. I'm proud to say that we've done over 10,000 screenings in our clinic, and we've made well over 1,700 referrals. So I think that this to me is table stakes. If you can't address people's social barriers to health, you can't do any of the other stuff that we're proposing to do. How are we doing it? Well, we've got some tools that we've created. So we have a tool called the Diabetes Data Doc that is a cloud population health management platform built in Microsoft Azure, currently being adapted to make it cloud compute system agnostic. So it could run on AWS or Cisco or Google, whatever. We use Power BI really for reasons that allow us to move quickly to build dashboards and then to test those dashboards with our clinical teams to find out what works, how we adjust for human factors, and how we optimize the usability of those dashboards to encourage them to take action on patients. And then we've created this My Care for Diabetes hospital-based mobile app that helps to drive patient and family engagement. And all of this is designed to lead to remote patient monitoring in 31 flavors with behavioral interventions that allow us to, at scale and at the speed of light, introduce emerging evidence-based interventions into care, evaluate whether they're moving the needle, determine whether we should conduct a full randomized trial, and then see whether the health of our population is improving. So the diabetes data doc looks something like this. This is not what I show software engineers, but this is what I show clinicians. We're pulling all the data in from the EMR, from all of the major device manufacturers and data aggregators. We're getting data now from Garmin, and we can get data from custom mobile apps or mobile apps in the app stores. Comes into a data lake. Data are turned into operational data through cleansing, deduplication, and mapping to data standards. And then we can serve these data up. So we send data out of this to the National T1D Exchange QI Collaborative. We're working on Smart on Fire applications to send some of the outputs into the medical record. And of course, we send them to the population health visuals that I mentioned. What makes this different than other solutions that basically bring data into the health system is that we're running advanced predictive analytics in here. So in addition to the run charts and dashboards that I mentioned, we actually have our machine learning models loaded in here. They're running on the data every day. We have an air traffic control system designed that allows us to see when a patient's entering an intervention, when they're in flight, and when they're landing and are eligible for another pathway of care. And as I mentioned, we have baked in dynamic propensity score matching so that we can look at the push of a button on whether an intervention is moving the needle, even at a very small sample size. The goal is to enable data distillation for insights and action. And once you start to do this work at scale, one of the things you realize is that the good old telephone and patient portal begin to fail you because we don't have enough staff to try repeatedly to connect with people to invite them into these pathways of care. Hence the design of a mobile application that we can scale and put into the hands of our families so that we can send them push notifications and invitations. We have 3 goals for this. One is to load all of our educational and self-management resources into it in a mobile-friendly format. Second is to create bona fide digital therapeutic interventions that are journeys that may last weeks or months. And finally, the third is to make it easier for us to invite and onboard people to interventions that happen off platform, off of this application. I'll just give you a few screenshots, right? We have a tool in here for sick day management. We're evaluating right now whether putting this tool in the hands of patients as a decision support tool can help prevent visits to the emergency room and hospitalization. You can see on the left here the categories for our resource library with now short video format diabetes education. And on the right, you can see how we string multimedia content together into learning journeys. And those learning journeys can be basic diabetes education, but it can also be our intervention on treating diabetes distress, which is delivered through this application, or another one that is a behavioral parent training program for parents of preschoolers with type 1 diabetes to address the unique challenges they face. Creates video. A new video to invite people into an interventional pathway in about 3 hours and load it into this system. Again, the theme is moving at the speed of light. And when we put it all together, what we hope to do is to create a system that really acts as a flywheel, where we have more data coming in to enhance our ability to forecast, to enhance our ability to take action. We take action, and then we can very quickly assess whether we're moving the needle on the outcome. And with that, I'll stop because we have very limited time and need to come up here as a panel. These are some of the people I need to thank. I'd like to call out the Helmsley Charitable Trust. And this is our logo. And there's our contact information. Thank you.
Could be laying right there. How do you hold that? Enjoyed all of this. I can get started. We're going to go ahead and transition now to a panel discussion. And what we want to do during this discussion is really first and foremost to open it up to you. But we want the questions from you today to really think about asking about the real world interventions that we heard with AI, challenges related to implementation, and also opportunities. So I'm going to be the moderator for this. And I want you to feel free to ask questions. Jeff has a microphone and he's in the audience. And then Francisco is monitoring the Zoom online. There's a large group also watching via Zoom. So Francisco will take the online questions, and then Jeff will take the questions on the floor. Again, questions related to the implementation of AI in real world settings, challenges, opportunities that you would like to know more about. There's two I see.
Hi, and thank you for a great session. I have a question for the gentleman from Georgia Tech that was working on the counterfactual models. So my question is, it looked like you did a 1-to-1, and I'm wondering why you wouldn't make a choice to find a higher number of matches, if you will, to get an average rather than just a 1-to-1, or maybe that was just how it looked in the in the presentation.
Yeah, so actually, this is one of the things we're working on now. This is one of the most common questions that I get, and I should have updated the slides, but we're currently working on expanding our algorithm to suggest multiple role models. Because we have had cases where the one that's initially suggested might have a completely different, disease trajectory altogether, even if they look similar on some avenues. So yeah, we are considering having multiple matches.
Great, thank you. And that also made me think a little bit about what Dr. Walker was saying earlier in terms of so much of the impact or outcome is based on the individual. And so I would think by having multiple individuals in the model, you could get more diversity in terms of some of those conditions you wouldn't either be able to measure or control for.
Right, exactly. Yeah.
Thank you.
Great presentation. Really enjoyed it. Ashby, my question is to you. How do you get around because I love the ECHO model, but as we all know, primary care is flooded and time is worth more than gold to a primary care physician. And so it sounds like, and maybe I missed it or I'm not understanding it, but it sounds like it's a lot. There's time that's involved beyond for the physician. So how do you get around that? How do you get like the clinician sort of buy-in in order for them to actually like engage in ECHO?
Absolutely. I think you build a really good program that has value and they come back. And so for us in the ECHO program, there CME is provided, so that's one incentive for the 1 hour echo session, but we do continual feedback with our providers. And what they say over and over again is this has value to them. They have valued so much our hub team. So this is really kudos to the multidisciplinary hub team. As they come on week after week, they really see there's value to these sessions and in terms of improving their ability to do better clinical care. We also know that they have appreciated having connections with other providers that are in similar situations, hearing the case presentations. So it's also allowed for a community building for the PCPs and FQHC settings. They're not in major academic medical centers. They don't get to hear grand rounds. They don't get to feel like academics. And so a lot of what this has done, I think, has given them a sense of value and importance. And they have so much respect for the hub team that in our situation, I think, and in Stanford's too, because I attend their sessions as well sometimes, there is so much of a relationship that is developed between the hub team and the spokes that's what keeps them here.
And follow-up question is like, is this done like on their own time, or is this done like during clinic time? So, you know, I get the CME part of it, but like the other stuff is like that, is that their own time, or then they're not getting reimbursed for or paid for?
We try to do it on what would be a lunch hour, which is not always viable, but they know ahead of time that's the time we offer. Some clinics incentivize the providers to come by allowing them release from clinical care during that time. But overall, yes, this has been on their own time, and it's done from 12 to 1 on each time zone. So Stanford does this for their time zone, and we do this for our time zone here. Okay. I don't know how to help with that. Are there questions that you want us to take from online? Okay, so we can take more from the audience.
Hello, thank you for all that you all said. I really enjoyed it, and I'm very grateful to be even included in this conversation. I'm from the Public Health and Health Professions College, more specifically a third-year clinical doctoral student in occupational therapy. And I have a question more geared toward learning about more of the ECHO program and the app. I just finished my clinical rotations in the cardiac ICU at Shands Hospital, and primarily in an inpatient hospital where I was on the stroke team. And so 95% of the patients or clients, we call them occupational therapy, had diabetes. And one of the main occupations is health management. And so when I'm with clients for 60 minutes in the morning doing their ADLs, their activities of daily living, which includes getting dressed, oral care, bathing, all of that. And during that time, I'm also in collaboration with the doctors and their nurses educating on diabetes management if they have that. And I'm curious to know more specifically with the ECHO program, on that multidisciplinary team, I saw that rehab clinicians and special or researchers were not included, and I wondered if there are plans to also include them on that team with that perspective.
We can always grow our ECHO team. I will say we have amazing representation right now. When you look at pharmacy specialists that have been part of this, peds and adult endo, social workers, et cetera. But I think that it's a great suggestion and one we can think about. I do want to pivot though here, because we want to talk about the AI interventions in our time that we have together. And ECHO is not formally an AI intervention. So really what I was talking about is how we address health disparities, and we want to really leverage the expertise here in AI and ask them some questions about their experiences implementing AI. We did get some questions ahead of time. Do you have some you want us to look at? Okay, I see them now. Francisco, can you read that out?
Whether we should grant any people with you more professional or not part of
I can, yeah, I can kick us off since I'm in clinic. First, I'll say to Andy, I would love that outcome because then maybe we could all go fishing or something. But I think the future doesn't involve replacing the current care providers. I think the future involves augmenting the current care providers. I think that some of the newest members of a diabetes care team include potentially community health workers. And I think that another type of individual that probably belongs in the diabetes care team these days is a data scientist. And that might be a little controversial, but I think we're in a place where we have to engineer the movement and use of data a lot to provide optimal care.
But I'll give it a try, but I'm not with the clinics. But all right. So in some of the tools we've been developing, so we have developed a tool that explains the treatment benefit of different treatment goals, like for the patients to achieve like blood glucose goals, blood pressure goals, body weight goals. What are the benefits associated with these goals? So this intervention was initially developed for the primary care clinician to be delivered as a primary care setting to introduce those benefits to the patients in order to boost their treatment compliance. But eventually, the project took a sharp turn, and we decided that it is the pharmacist who is the best role, who is at the best role to deliver these interventions. So I want to mention this example as a way to describe that the AI sort of reduce the barriers for more people to get involved in this care, to be integrated in the care model. So I do see a chance for what Muir mentioned in the future.
I have one question for each of you, and we don't have to do all these because I know we have 1 minute, but two are policy related. So for Dr. Clements, I know you mentioned there are billing codes for remote patient monitoring, but would this be currently sustainable without grant funding to do remote patient monitoring, or do you think it could become sustainable in the future with value-based care?
I think it can be sustainable with remote patient monitoring. And the reason is that CMS has defined that it doesn't have to be a physician or a prescriber who's actually delivering the visits, that it can be that other skilled clinic staff are delivering the visits. So for instance, diabetes educators under the supervision of a prescriber. And so I think that's what makes it a sustainable model. The other thing I will point out is that these codes are designed as a funnel. So the funnel says that you can bill once for consenting and onboarding somebody to a remote patient monitoring device. And the definition of a device could be hardware or software that collects and transmits the data to the healthcare team as an SAMD. And then you can bill every month where there's not an in-person E&M code billed for the transmission of data. You can bill the interpretation of that data, and you can then bill for the first and second 20 minutes of interaction. So you could be billing 80% or more of your population, just for sharing data every month, and then selecting the people who concern you the most to interpret data on, and then selecting the people from that group with whom you want to have an interaction, right? So it's a funnel.
Thank you.
Yeah.
Then for Huey, this is a little bit cynical of me, but when you're talking to payers about reducing barriers for these very high-risk groups that would really benefit from a particular medication, do they care about long-term health outcomes? Because my impression is that since people switch insurances so frequently, a lot of times the payers aren't looking 10 years into the future. They're more concerned about, like, right now this medication is very expensive. And so I don't know how many conversations you have with them, but are they kind of open to?
hard, difficult question. I think it's yeah, it's a good question. I think what information the payers values, right? And your observation is very correct. That's the short term outcomes values more to them for sure. But from my observation is that most of the large payers like the Blue Cross Blue Shield in certain states, right? When payers become a dominating payers in a certain stage, they start to take over this what they call the social responsibility roles, and they start to appreciate about keeping a good health conditions for their covered patients. And what I have observed is that even some of the take Blue Cross Blue Shield of Louisiana, for example, they even launched their $0 copay program about any people who have chronic conditions. So they want to use this kind of a program to eventually maintain a good health for the populations. And that program is not really supported by the economic outcomes. So I guess your observation is right, but the payers also have their priorities based on where they stand. So as the researchers, what we do is that we provide a comprehensive documentation and evidence about every aspect of these, like short-term benefit, long-term benefit, the economic value, the cost effectiveness, the incremental net benefit, everything. And then we can have this ongoing conversation about how to refine the program and how to refine the plan. So that's what typically the model looks like.
Thank you. And then Dr. Garcia, sorry, hogging everything. This is not a policy question, but for the model patient, are you influencing the factors that the AI is using to match a model patient, or is it kind of this black box sort of thing where the AI is just using who knows what to match the patient? Because I just imagine there's a lot of intangible factors for why a particular patient would respond well to a specific medication that wouldn't just be like, you know, race, whatever, you know, like a list. So I was just curious about how that happens.
Yeah, so and this is all part of the algorithm design that we are still working on, but so in part we are telling it kind of what a good role model looks like. That's something we're allowed to change. We're also telling it what it's allowed to do. So for example, if you can imagine, like we try to focus on recommending role models who's like if you were to change to that, it would be actionable changes. So for example, you can't change your age, you can't change your race and ethnicity. So we try to stay away from those. Or like, you know, if you're currently on antihypertensive medications, like we're not gonna recommend a role model who's not on those, because you know it's very different trajectory. So in that regard, we're kind of constraining what the algorithm can pick. And then on the other hand, we can kind of, if you recall, I had a slide that was like, what we're trying to do is minimize the effort it takes to reach the targets set by the role model. And however we measure that, that's really tunable. Like that's part of what we're still trying to work out, is like, how should that look? You know, we kind of picked some way that seemed reasonable based on what other people have done in other areas, but that's not the be all end all. There's a lot of work that can go into it.
Thank you.
Well, we want to thank everyone so much for your time, for your participation, for our amazing speakers that came
Ashby,
in.
do you have
one more? Oh,
one more? Sorry. Kind of
One more.
even kind of a wrap-up question. So having worked with both Ashby and we on both sides of the issue, what I've often struggled with is how do we make that, you know, going from we're building it ourselves, AI models and all, to implementing and disseminating it in the actual FHQCs and those FQHCs and those places. And is it going to take that 17 years of implementation and dissemination, and is everybody going to have to build it themselves, or the model's going to be so costly that only us big academic centers could afford them? So any thoughts on that? And yeah, exactly.
Yeah, I can talk about what we're doing, and I don't know what's happening with Project Echo, but with the Rising Tide Alliance models, you know, we made more parsimonious models. We're satisfied with the performance metrics right now, although we're continuing to do experiments where we're adding novel data features to the models to see whether we can boost performance, sort of one data feature at a time. We have models that we think are immediately disseminable to other diabetes centers. We're a member of the T1D Exchange Quality Improvement Collaborative. We specifically chose 18 data features that are common to every center, all 60 centers in the T1D Exchange Collaborative. We're currently working on a manuscript analysis that will validate our model or alternately hypertune parameters to create a valid model in other centers' data across the collaborative. And if we are able to do that, they have a portal that any center can access on any day of the week, which would allow us to run this in production and allow centers to immediately access the output until the day when they can get the insights into their own electronic health record.
And along that line, just, and this may be too much in the weeds, but have you had success in using things like Smart on Fire to get it back and forth in and out of the
Yeah, so
EHR?
we actually have a team right now, software development team that is working on the design. And soon we will run the sprint to actually build the Smart on Fire application to push data into Cerner from our diabetes data doc population health management software. And once we've got that, we could do it to Cerner or Epic or wherever.
Great, thank you.
Want to comment before we close on that question?
Our team also working on the Smart on Fire. So we are kind of integrating our Bravo model, the simulation model in the EHR setting. So currently it's two-lane EHR. So it's not really even OMOP, dot common data model. It's just not even Epic. It's just a two-lane specific CDW. And we use Smart on Fire to pull the data and automatically convert the data to a format that our algorithm can read. And then we generate the outcome, and basically through the Smart on Fire, we push the outcome back to the system, the EHR system. So the project is currently funded by the NIH and will be finalized by June. So maybe by June, we will have a well-cooked protocol we can share. So maybe at that time, we can see some good experiences. Yep.
Thank you all. We're going to officially call it a close. So thank you for coming.